FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.
Esse é o FRêMITO Podcast Vascular, direto do Congresso Science 2023. A gente está tendo o apoio aqui do Curso BIZU e estamos tendo a máxima honra de receber o chairman do Congresso, Dr. Nicos Labropoulos, direto de Stony Brook, está aqui na mesa com a gente. Vamos trocar uma ideia sobre o Congresso e também sobre angioplastia venosa e por que os stents deixam de funcionar ou não depois de um tempo. Nicos, you are very welcome. Thank you very much to join with us.
So nice to be with you. It's always a pleasure.
It's a very nice meeting. Congratulations.
I'm happy because we getting better and better, and we're learning from each other. And it's nice to see how different people with different expertise and background can be together and discuss many problems that they can improve the clinical practice day to day.
Yes, of course. And to see the Doppler ultrasound in the same room, Adriano doing the exam, Fanilda doing the exam, you explaining, was amazing. Very, very nice.
I'm proud because, all the new things we do in our research, I pass it to our Brazilian friends, particularly to Adriano and Fanilda, because they teach a lot here. And it's nice to disseminate knowledge and also conquest new things.
Of course. So let's start to talk and speak about our subject. And what do you think, where are we in venous stent angioplasty?
This is a very interesting topic, because you see, stenting has been around for a while, but its usage now has increased exponentially. Now, there's several things can arise from this. One, too many people who need a stent don't get one because their disease is not discovered. And too many people, right, that getting a stent without needing one. Mm-hmm. And it's the irony, how can you have a disease where you have, under treatment and over treatment? So obviously, first thing to do, like guys, you do your educational activities here, right? And you go to work promoting knowledge, is to educate people. Educate different physicians and educate the health care professionals and the public. So we start doing the right thing. So in that way, we have the right doctor treating the right patient for the right reason. So now the next area we need to understand, we went a long way with the development of the stents, having just the wall stent, which is not even an indication, was used without any really permission. But it did well over the years, and now have better and a lot more stents that you can have place them with better precision, and also it's much easier to place them. However, some of the problems remain, and myself and some other leading authorities, for example, Steve Black, who's the surgeon in chief in St. Thomas Hospital in England, then Kus Desai, who's probably one of the best intervention radiologists in the world in Northwestern University, Chicago, and Makis Avierinos, who is a professor of vascular surgery at the University of Pittsburgh, right? Having a common interest, we try to combine our data in a database where most of the information is collected in an honest and transparent manner. And everybody can go and see every single patient in any detail without having to hide anything. So in our effort, we have collected now 250 stents that have failed. Currently, we have analyzed 198 stents. And I give you the results of preliminary analysis. There are some publications that talk about it, but nobody had enough stents together with credible data from credible universities and credible people. So what we found out is the following. One major issue is the anticoagulation. And this has to do, one, with every time you take a medication, you have to be compliant, right? And people with anticoagulation can be also not compliant, like when you take a pill for cholesterol or high blood pressure. Do you know, for example, that the 1 year compliance rate for taking a medication for high blood pressure or cholesterol, it varies with the disease you have, and it never is perfect. If a peripheral artery disease, your compliance at 1 year is 55 to 60%. If coronary artery disease is about 80%. Even with coronary artery disease, which perceived by the public worse than anything, still the compliance is only 80% at 1 year. So anticoagulation is not any better, right? So now anticoagulation have other problems. For example, then is if the anticoagulation has been stopped prematurely by the physician. Because, for example, they use the standard guidelines. Well, you have a stent, we have a DVT, 1 episode, give you for 3 months. But it's not like that. We're figuring out now that when you put a stent in a post-robotic limb, you have to put the patient on low molecular heparin for 1 month because the DOACs have a high failure rate on a bare stent in a venous setting. And therefore, now that people know more about it, they use low molecular heparin for 1 month at least, and then switch the patient to a DOAC. But for how long do you keep a patient in a DOAC? Is another question we haven't solved. Because in our databases, we have people who took the full anticoagulation for 1 year, but 2 years later developed a thrombus. So we're learning now, likely in people having, iliofemoral DVT and a stent place, we should keep the anticoagulation for probably longer. And we do not know if it should be the full anticoagulation forever or full anticoagulation for 1 year and then switch to half a dose. But you see, medicine is evolving and we're learning about these things. Another issue with anticoagulation is the following. For how long you give anticoagulation is one thing, but should you use antiplatelets, yes or no? Nobody knows. When we give antiplatelets, do we treat the patient or ourselves?
Probably the doctor and society.
So these things you have to learn. Also, I notice, look, these are 4 credible universities and people that we talk together. The way we mark our databases, they don't speak the same language. So now I'm doing a lot of work for 6 months to homogenize the data by talking back and forth to the people to collect the accurate information. Because the terms we're using are not similar. And as you know, in medicine in general, one of the biggest problems is miscommunication. I see it as not as a professor, but also as a high-level administrator in my hospital, I see it all the time. And if you correct the miscommunication, you save a lot of money and time and resources. And clear with the database, despite having 4 people from great centers with the best, desire and expectations, still have to solve problems. So much that Dr. Steve Black and Chris Desai, they talk to the FDA, and right now it's called a group called VARC, and through the FDA, we try to create a common terminology for all deep vein diseases. So we speak the same language all around the planet. Perfect. We finish the first 2 hour meetings, and then we're gonna go to final stages. We're gonna propose the proper terminology to the FDA, and when the FDA receives projects, it needs this terminology so everybody understands what we're talking about.
Dr. Nicos, in this study, are you dividing by extension of the stent and also about the indication, if it was acute thrombosis or chronic occlusion?
A great question. Absolutely for everything. Because this database, I would say complete, but almost complete. So we have the type of the stent, the length of the stent, the time was placed, the time of secondary interventions, right? Everything. Also, other problems I did not mention is, anticoagulation is a big one, also inadequate inflow. I can't believe in 2023, still people putting stents with inadequate inflow. And we know if you don't have enough flow in the entry veins, even at the full anticoagulation, the stent will occlude. And it's a disaster, because you put something to make patient better and the patient is back to square one. And if you do catch it early and the thrombus becomes collagen like it does, it's very difficult to open the stent and maintain it after. So, and then we're learning now that our follow-up with the stenting initially is to be more frequent. And also because we want to catch a stent before it occludes. Because if you occlude, then you have a different animal, right? So these are very important issues. Other issues we found for is technical errors. I can't believe that, people, they thrombolize the patient, yet they put the stent in, but they don't cover the stenosis in the proximal iliac vein. So this is outflow disease. Or sometimes they don't extend the stent to the distal point, right? And that's why Dr. Igor yesterday, he was asking me live in the meeting, Nicos, should I have to extend the stent farther down? And obviously even Dr. Black and myself said yes, and he's rethinking now to extend the stent on the patient we saw live yesterday. And that's a common problem. And imagine, Igor, right? Dr. Sinkos is an experienced user. So imagine what happens in the community.
Sure.
Right? So things we're learning, and also with the evolution of technology, I was becoming more available. So you have, intraluminal views, so which are much better than venography and other testing. And during actually the procedure, which is your ability to react and do something. So, but this cumulative experience, hopefully, is gonna get us to reduce the technical errors, right? Or we say the iatrogenic mistakes. So we reduce the number of complications and have a better clinical outcomes for our patients.
And do you think the stent design has something influence on the fail or not to fail?
Well, it's something we need to check now, because you see, all the stents we use are fairly new and none of them is perfect. And some have advantages and disadvantages. Right? I'm not going to name stents for commercial purposes, but you have one stent that's extremely stiff and it doesn't take the shape of the vein. The stent can take the shape of the vein, but it's not stiff enough. Right? But sometimes now the newer stents, they're finding the balance between these two. Right? Another thing is also how long will be the stents. Another issue you have not solved is what do you do for the common iliac vein union. See, like in the aorta, we put an endograph with two limbs. I think the Gore companies try to create this right now. They create the first stent for the vena cava, and they have a second project with limb extension into the iliac veins to solve the problem with the double barrel we use. And you saw the patient yesterday live. You see, one stent was crushed. Of course, the patient is asymptomatic. If they're asymptomatic, what we're going to do? So you see, this a lot of technical issues we need to resolve. Also, we need to address issues with the flexibility of the stent and the ability to put the stent very safely below the inguinal ligament. Mm-hmm. Currently, the stents have shown that actually to be really good for placing them below the inguinal ligament. But in my opinion, not enough time has elapsed to know exactly how good we are.
Professor, we would like to thank you for your presentation, and as a take-home message to our listeners and the Congress people, what would you say to us?
Because yourselves, you propose knowledge, I'll say the following thing, is with a lot of pride, all of us try to eliminate our gaps of knowledge, because it's only then you step on a solid ground and give good advice to your patients, to our trainees, right? And with honesty and pride. Because a lot of us getting a position, being busy in our lifestyle, right? We forget to focus on improving ourselves in a meaningful manner every day. Thank you so much for having me here.
Thank you very much.
Very nice, Nicos. What you can expect for Venus Symposium next year?
Yes, the Venus Symposium, as you know, we collaborate with Brazil,
Sure.
and with the our science meeting in here. It's going to be on May 8 to 11, and after COVID era, our first meeting live in New York was a great success. And this time we've added an extra day where we have the Wound Care Symposium.
Whoa.
And for you guys that you educate so many people, I'm proud to tell you we had 151 fellows.
Wow.
Primarily for vascular surgery and interventional radiology, some for interventional cardiology, and a few more from phlebology and vascular medicine.
And can we expect for a Venus Symposium run in Central Park?
Absolutely. Like we did here in Ipuapuera this morning.
We did very well.
I think it's amazing.
Yeah.
As you know, in being Greek, in the ancient Greeks used to say, a healthy mind in a healthy body. And I think we have to embrace, as healthcare practitioners, to embrace this, principle to look after ourselves, and feel good. And because if you don't take care of yourself, it's difficult to take care properly of others. I mean, you could, but it's nice when you do both ways.
Yes, perfect. Thank you to give us this opportunity to stay here with FRêMITO Podcast Inside Science. Thank you very much.
It is a pleasure, and hopefully sometime in the future we'll do something else so we can pass new messages to your audience.
Of course.
Thank you.
Thank you again. Não deixe de continuar acompanhando os episódios do FRêMITO Podcast Vascular, direto do Congresso Science 2023.
FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.